Hello everyone, this is Dr. Azid Al-Amin, General Practitioner from Inpatient Department of TBRC. My topic for today is post-stroke rehabilitation. Our objectives in this topic will be introduction, statistic rate of stroke disability, clinical effect of stroke, what is a post-stroke rehabilitation and what is the main area of post-stroke rehabilitation, and discharge and outcome plan. In introduction, we all know stroke is a major public health issue with high mortality and morbidity rate. Recent medical advances result in improvement in mortality rate, but the disabling long-term effects of stroke are still prevalent. So, post-stroke rehabilitation improves patient outcome by decreasing the chance of secondary complication and maximizing the patient independence despite their impairment. Post-stroke rehabilitation is a process delivered by interdisciplinary team experienced in this process, and this process it contains main focus area or a lot of area all together work together to ensure a holistic approach. Stroke recovery is a heterogeneous and therefore it is very difficult to predict a post-stroke outcome, but the importance of early intervention and ongoing outpatient rehabilitation after discharge is stressed. Cerebrovascular accident or a stroke, as we mentioned, it's a leading cause of morbidity in the recent year. And although there is a lot of improvement in medical treatment of the post-stroke, but still there is many survivors of stroke remain with a significant disability. For example, we have 40% of patients who survive stroke remain or left with moderate disabilities, 15 to 30% with a severe disability. It can be assumed that the greatest health effect and functional burden on stroke survivor and their family are the possible long-term disabling effect. So rehabilitation, if initiated early after stroke, has been shown to assist with reducing complication and residual post-stroke disabilities. However, despite the increasing evidence that post-stroke rehabilitation is beneficial, still a lot of healthcare providers or professionals are unaware of the importance of post-stroke rehabilitation program. In clinical effect of stroke or clinical presentation of stroke, the disabling effect or disability of the stroke are dependent on the affected area of the brain. It's being divided into motor presentation and sensory presentation, but most of the patients of stroke will having motor impairment by rate of 80%. It can be in the face, upper limb, lower limb, in one side of the body depending on the affected area of the brain. Anatomically, the brain can be divided into four main areas: the left, or what we call it dominant hemisphere, right or non-dominant hemisphere, the cerebellum, and the brainstem. This division make it easier for the physician to know the possible effect of the stroke. There is another division called Oxford stroke. It's classified the stroke either to hemorrhagic stroke or infarction stroke. The clinical stroke presentation have mix of neurological presentation. It varies from hemiparesis, hemiplegia, sensory change, visual change, cognitive impairment, speech impairments, and functional outcome can be predicted according to the various of syndrome described. What is a rehabilitation, or what is a post-stroke rehabilitation? It's a goal-driven process that attempt to maximize the functional independence of patients who suffer from a variety of stroke related disability. The main aim of post-stroke rehabilitation is to assist the stroke survivor to return to their pre-morbid function or as close to it as possible within their family, community, or even work environment if it's possible. Rehabilitation can be delivered in inpatient or outpatient setting. Inpatient rehabilitation is preferable as outpatient rehabilitation tends to lack the intensity offered by the former. Although admission criteria it's differ from one center to another, but typical stroke patient who qualifies for inpatient rehabilitation if the patient requires 3 or more modalities of intervention or if they are unable to transfer independently. As we said, post-stroke rehabilitation is delivered most effectively and efficiently by an interdisciplinary team of healthcare professionals working together to achieve common goals. Constant and effective communication between team member and the patient allows for more holistic approach, and good communication among team members allows all individual professionals to use their experts to build on that of another team member. The team usually include nurses, medical practitioners, physiotherapists, occupational therapists, speech and language therapists, social worker, and dietitian. In addition to some disciplines or professionals are included depending on the case of the patient or in the patient situation. What is the main focus area of post-stroke rehabilitation? The main aim or focus of post-stroke rehabilitation, number one, is reducing risk factor and preventing the secondary complication, because we know a high priority of the stroke patient it will tend to recur. Therefore, careful management of risk factor or the underlying cause it's more important. On another way, the treatment and prevention of secondary complication, and which this secondary complication we have number one, spasticity. Most of the patient of stroke patient they will get spasticity, but patient mobility can limitedly greatly by spasticity. A number of therapeutic intervention may help, like passive stretching, splinting, posture and movement therapy. There's another medication can be given like baclofen or olanzapine or even injection of botulinum toxin. Number two is the pain. Nociceptive pain in the shoulder is the common in a stroke patient. Physiotherapists are often able to assist with strapping, massage, or passive movement. Although there is another also medication like can be given like gabapentin. Number three is a pressure ulcer. The risk of developing pressure ulcer is a high in stroke patient, attributed mainly because of their decreasing mobility. So regular turning when patient in bed, adequate nutrition and pressure care, education for the patient, family and caregiver are very helpful in preventing pressure ulcer. If pressure ulcer is developed, we need a treatment by a physician and nurse who trained on wound care management. Number four, we have deep vein thrombosis and pulmonary embolism. A stroke patient are there having high tendency to develop to develop deep vein thrombosis and pulmonary embolism because of their decreased mobility. So early prophylactic management like using low molecular weight heparin, compression stocking are beneficial. Physician and nurse also need to be alert to any symptoms or signs of this serious complication whenever it's deep vein thrombosis or pulmonary embolism. Number five, we have urinary or fecal incontinence, which is common complication of stroke. Most common management is using of indwelling catheter in acute management if the patient is incontinent to prevent urinary retention and skin breakdown. But the prolonged use of catheter although can lead to infection. Fecal incontinence is less common long-term problem as it's often resolved within first 2 weeks after the stroke. Number 6, we have aspiration pneumonia, which is more common if the patient is having dysphagia. Intervention by speech therapist help to manage this risk, but still the physician and nurses need to be alert if any symptoms of sign of aspiration pneumonia occur. Number 2, in area of post-stroke or process of the post-stroke rehabilitation is the therapy-specific rehabilitation. The therapeutic discipline traditionally involved in post-stroke rehabilitation are physiotherapist, occupational therapy, speech and language therapy. The role of physiotherapist and occupational therapist often seem to be overlapped, although both disciplines work predominantly with the motor impairment of stroke patients. Their approach and focus of the impairments differ. Because, for example, physiotherapists focus on the correct positioning of hemiplegic patient as well as early mobilization and mobility of patient, whereas an occupational therapist work toward the resumption of activities of daily living like grooming and dressing, often incorporating the use of assistive device. The occupational therapist is also involved in early cognitive screening, and cognitive rehabilitation is undertaken in conjunction with the speech and language therapist. Return to work assessment and driving assessment are normally the domain of occupational therapists. Many stroke patients suffer from range of cognitive, communicative, and swallowing impairment, and therefore speech and language therapists are needed to be in the team, and they work on it. Number 3, we have patient and family or caregiver education, which is more important in the patient plan of post-stroke rehabilitation. And they should be a part of this interdisciplinary team. They must be receive education on the cases and the consequence of recovery, and there should be interaction between the interdisciplinary team and this families or caregiver regarding the goals and progress. Number 4, psychological support, because there is a variety of neuropsychiatric sequelae after a stroke. The most common is a depressive symptom. Most of the patients after stroke, they will have post-stroke depression in the rate of 25 to 75% of patients. However, it is not unusual for a stroke patient to experience periods of emotionalization or feeling of fear and anxiety, sense of grief for their physical losses or changes. This can be all normally dissipated with the time and can be adequately managed with the support of the interdisciplinary team, including the counselor, psychological counselor. But if these symptoms persist or interfere with the patient's other therapist, so in this case we need to refer for psychiatrist for seeking medical advice and treatment. Number 5, we have nutrition and diet. Nutrition also is the very important part of the rehabilitation program, and it should be from the start part of the process, because most of the patient will having malnourishment either because of the swallowing problem or communication difficulties, which may result in patient being unable to adequately express their dietary requirement. Finally, we have discharge and outcome. Discharge plan is very important part of post-stroke rehabilitation. Provisional discharge plans made in the early stage of rehabilitation allow family or caregivers to be part of this plan because they maybe need to make any necessary changes or alternation in the home setting or the outside settings. If there is a possibility of returning to work, they should be also included in discharge plan. Early and ongoing communication between interdisciplinary team and the patient employers can greatly assist with the reintegration into workspace. The support given to patient by their family and caregiver after discharge from inpatient rehabilitation plays a significant role in determining a patient's long-term outcome. Another relatively reliable indicator of stroke prognosis is the degree of motor impairment. There are also other impairments such as dysphagia or urinary continence. Regarding severe disabilities levels after stroke, however, the heterogeneity and multi-layered nature of stroke make it difficult to accurately predict post-stroke prognosis. A patient post-stroke rehabilitation must not discontinue on discharge from an inpatient rehabilitation unit. He should continue rehabilitation for up to 1 year after a stroke has been shown to assist in the overall long-term outcome of the patient. Referral to appropriate healthcare professional need to be made time-wisely by the inpatient interdisciplinary team in case to ensure that there is a good structure in place for continuation of patient rehabilitation after discharge. And here we are finishing our topic, so thank you all.